This is Sumit Bhatia. This is not because I'm biased, but maybe I am. So I have a question. Do you know, when you, it's good to look at the pediatric data, but when you look at access to care and how complicated it is to give a pediatric regimen, and even if you discount what Dr. Kantarjian said about integration of newer agents into hyper-CVAD, when you look at access to care and delivery for these patients, short of some academic centers, don't you believe that a simpler regimen, as has been expounded by Dr. Kantarjian, allows for better access and maybe better outcome at the end of it?
Well, I never discount anything that Dr. Kantarjian says.
Not discounting part of it, but if
I
you
don't
take
always
into account
believe it, but I don't discount it.
If you take into account access.
No, I mean, I think there's no question that it can be difficult to administer the pediatric type regimens. There is a learning curve, but Dr. Stock showed in CLGB 10403 that it can be done throughout North America, even in places that have low socioeconomic patients coming in. And we have studied that regimen in terms of what type of patients get it, and it's applied, it can be applied safely. And as you can see, the results speak for themselves. So, you know, I think it's quite possible that that can be delivered. We're not, doctors aren't stupid. They can learn a lot of things. And, you know, but I also think that some of the modifications that Dr. Kantarjian mentioned are very exciting. And, you know, once they're going to be shown to be duplicated outside MD Anderson, it'd be great to have a more simpler regimen for more people, no doubt about it.
Yeah, I would argue that in the CALGB regimen, it doesn't take into account the denominator of the people who do not make it to the trial. And in care, as it is delivered in larger communities, there are a large number of people who are not able to make it to quaternary clinical centers which deliver that kind of care.
Those are intent to treat analysis, so people who got enrolled in the trial. I mean, I don't know how many didn't get enrolled.
Okay, I got a question, Sumit. You can hug the microphone there. So I have a question for my lymphoma docs. And my question is, all the lymphoma docs, you know, for CAR T therapy, it seems that there's some controversy as to what the preferred agent is for diffuse large cell lymphoma. And there's even additional controversies as to whether CAR T therapies are safe in mantle cell lymphoma. And I just want you guys to make some comments on CAR T therapies in general. Do you have a preferred agent, and why for diffuse large cell lymphoma, and maybe the potential concerns of CAR T therapy for mantle cell lymphoma toxicities?
I definitely think that there is a toxicity difference in mantle cell lymphoma, both in the clinical, that was reflected in the clinical trials, and my experience in the commercial environment outside of the clinical trials. We have, despite the data, I think the patient population was different between axi-cell and lyso-cell in that regard. We've chosen to learn one CAR T-cell well, and that CAR T-cell for our historical nature has been lyso-cell. I think it has broad labels now, with both in CLL, follicular, mantle cell, large cell, multiple different spaces. And I think that allows you to actually see the differences within the disease landscape itself too. I think we are learning about how to use, what to use before CAR T-cell, and what we potentially can use after CAR T-cell. And I'm really excited about, I think somebody made the comment about radiation therapy as a pre-apheresis, post-apheresis possibility for controlling not only the disease, but also there's data at Astro, I think about almost 2 years ago now, showing that radiation may actually decrease the risk of CRS as well as ICANS, and I think it's one of the most underutilized therapies around the CAR T-cell period of time.
So, Dr. Beer Harry, so, you know, we have 2 CAR T-cells approved for mantle cell lymphoma. For the younger people who do not have so much morbidities, I would choose breast carbagine autoleucel corticosteroids for the younger people who can tolerate the toxicity. But for the older people and for the people who have comorbidities and is fragile, I would use the lysocell because the CRS is 5 times grade 3 less in the lysocell than the Brexu, and also the ICANS is dramatically manifold less. And so we are getting good results on both trials, with both products.
Just to give a little counter to what Matt said, we have actually the opposite, where we have every product available and we use all of them. So we end up having a very individualized discussion. There are some differences, of course, in toxicity that I think it's fairly well described that toxicity with Axicell is probably a little higher, but there's also less non-conforming product. There is a very fast turnaround time. And for younger people, especially now with us having gained a lot of knowledge, compared to when you first, when you started your talk and you showed that mushroom cloud, I think CRS and ICANS now is much better controlled, and we know how to deal with it. Very few people go to the ICU anymore. So I think it's a very individualized discussion.
Hi, I'm Courtney. I'm a nurse practitioner with CHN. I have a question for Dr. Ansel regarding favorable risk Hodgkin's lymphoma. In patients who experience acute indications to stop bleomycin before they've gotten to that first mid-treatment PET scan of a pulmonary toxicity during or post-treatment, what is your preferred treatment modification to avoid suboptimal therapy in an otherwise good risk population?
Very good question. I would say that first thing just to note is that actually if you look at the data overall, bleomycin lung toxicity is much more common when you get past about cycle number 3. And where do I get that from? If you look at BEP that is typically given for testicular patients, bleomycin lung toxicity is almost never seen. And part of that is just because I think the risk increases over time, although it really isn't dose dependent. On the other hand, as you mentioned, if you have a high-risk patient and you do feel that the patient is having a good outcome, you can drop the bleomycin even in those patients. I would say, though, that I would then really consider adding the radiation treatment because you do, as you point out, not want to under-treat a patient. And quite frankly, the thing that most patients despise the most is relapsing. So they would really like to get into remission and stay that way. So I think, again, I want to be very careful to say that radiation treatment very much has been given a bad rap, and I'm not entirely sure that it was fair because I think particularly with better imaging and protons and the like, actually toxicities are probably lower. So in your patient's case, I think safely drop the bleomycin. I think bleomycin lung toxicity is a devastating problem which should be avoided at all costs, and I would just simply make sure the patient got appropriate radiation.
So without trying to shift gears and get brentuximab or Opdivo approved, you would simply just omit and then
So
add
I couldn't hear your
ISRT.
question, so not adding in the new agents, is that what you're saying?
Yeah, so rather than shifting gears and getting away from ABVD altogether, trying to get insurance authorization for a non-bleo candidate and doing brentuximab or Opdivo, you would just complete ABD and then do ISRT.
Well, so again, I would just be
On the back
cautious
end.
because reasons to drop bleomycin, pulmonary, etc., are often the reasons to be very cautious for nivolumab and other agents because pneumonitis, etc., could be a significant risk. So again, I would just make sure that you are clear on why you're leaving the bleomycin out versus other risks that would be really just reintroduced with nivolumab or brentuximab.
Thank you.
Quick question for Dr. Woyach and Dr. Bird. It did not seem to me, Jen, when you were giving your talk, that you have yet gotten to a point of saying you will do the AMPLIFY regimen now for patients as fixed duration therapy. So my question is, if you have a patient who says, I really don't want an injection, but I want a fixed duration therapy, and both drugs are approved and you could prescribe them, both of you, I want to get your comments in terms of doing that.
I actually have given the AMPLIFY regimen for a few patients in kind of the scenario that you say, somebody who really wants a fixed duration regimen, who would prefer not to have the time-intensive nature of the obinutuzumab along with the venetoclax ramp up. And specifically, I've done it for people who have IGHV mutated disease, because I think, even with the 3-year data, we're already seeing the IGHV unmutated patients start to relapse, and I think that those curves are going to become even more separated as time goes along.
But can I ask you a follow-up question? So you gave the full talk about CLL, and I didn't hear a sentence about the 2-year BTK inhibitors and venetoclax, which appears to reduce the relapse rate significantly and potentially cure CLL. So why are the CLL experts so much afraid of mentioning the 2 years fixed BTK inhibitors, venetoclax?
Well, I do think that it is unlikely that we're curing CLL with that regimen, even with the 2-year duration.
Okay, I'm going to remind you about this 10 years from now.
Please do.
I think we are curing CLL at a high rate, and I don't know why the CLL experts are so afraid of mentioning cure in CLL.
Well, I think, the randomized trials that have been done have all used a 1-year regimen in frontline CLL. And certainly there might be an opportunity to improve upon that with MRD-guided treatment, for example, especially in IGVH unmutated patients, probably not in the mutated patients. But I think we just don't have enough robust data with 2 years.
Since we're debating, I'm going to make 3 comments. With ibrutinib, venetoclax, and obinutuzumab, we looked in our pilot study. We looked at, which was not a pilot, it was over 60 patients. We looked at not even 9 months and 12 months of venetoclax, and there was no difference in response in the upfront setting. The second point is, in most of the studies have shown that you don't get added benefit from venetoclax beyond the year unless you're...
That's not true. We have done 120 patients with ibrutinib venetoclax for 2 years, and we have now 80 patients with pirtobrutinib venetoclax, and the data is amazing. And in the ibrutinib venetoclax in 120 patients, all stopped therapy now for about 5 years minimum, and only 18 of the 120 have relapsed. I'm going to state it very clearly today that the CLL is curable today with 2 years of an optimal BTK inhibitor, pirtobrutinib venetoclax, and all those randomized studies are using either 1 year or single-arm, single-agent therapies, or venetoclax with obinutuzumab. We need to move to the BTK inhibitors with venetoclax for 2 years.
So did I miss a randomized study showing 1 versus 2 years of venetoclax, Dr. Kantarjian?
No, so there's no 1 versus 2 years, but there are comparisons, and at some point in time we have to stop believing in the randomized studies like they are a gospel. So every time we show the MD Anderson data, they say, oh, single institution, we'd like to see it. I see it 10 years later in a randomized trial, and nobody remembers. For example, in APL, we developed the atrarsenic trioxide in 2000. In 2012, a randomized study shows the same, but now it's called the Lococo regimen. Nobody refers to the MD Anderson data. There's not a single arm trial from MD Anderson where we compared to rigid historical controls where we did not show the data to stand in randomized trials. In contrast, there are randomized trials like the study of ALL with inotuzumab, where the dose was a bad dose, and the trial was falsely negative. So randomized trials can be as misleading as single-arm trials when they are both badly designed. If you design good trials, even single-arm trials, compare them to historical data, the results will be positive. Remember, in all of Europe, nobody is doing randomized trials in ALL. They are all doing single-arm trials now.
So getting us back to the focus of curing CLL.
Okay, guys.
I would disagree. I would disagree that it's going to be this regimen.
One last question, though?
It's going to be immune therapy adding to, say, the 1 year regimen, and the 2 year regimen I suspect if we get 10 years, we might see, I say, a good amount of treatment-related myeloid neoplasia, which we still need treatment for.
I have a quick last question for Dr. Cook. My last question for you is, of the BCMA targeting bispecifics for multiple myeloma, do you have a favorite son or daughter or cousin?
I love my children. Can you hear me? Yes, I love my children all the same. I teclistamab up front, but can you hear me out? Yes, I used teclistamab to be up front for BCMA bispecific antibodies, and I would use alketamab afterwards. But there is no preference for elranatamab.
Thank you.
So I have a question for the CLL expert here, Dr. Bird and Dr. Woyach. We're now thinking about the cure for mantle cell lymphoma, how to define it. I would like to learn from you, what's the definition of cure for CLL, and how many CLL patients have you cured?
Well, I think for CLL, I think it's really going to be a functional cure where you're giving a therapy that allows people not to need another treatment in their lifetime. To me, that's a cure for CLL. So I guess if you define it like that, pretty good amount, since many of them are quite a bit older.
We know that this is we were designing the moonshot program at MD Anderson. We said, what's the cure? Like 10 years. So we all discussed our 30%. Okay, so people have no doubt after 10 years of large cell lymphoma in continuous. For follicular lymphoma, after 30 years, continue to provide 20% people after 30-year follow-up is a cure. So for mantle, I think it's probably 15 years. Future, we have now. I just don't know that number for CLL.
Yeah,
I think we may not, because CLL has lymphoid prime stem cells, what we may discover is we have patients with 10-year remissions, and I've seen this happen, where they develop another clone of CLL that's different. So, I agree with Dr. Woyach.
Yeah, you see it with the FCR data where...
I think we're having time called on us. I would suggest that we continue our discussion out in the reception. We're going to have some hors d'oeuvres and refreshments, and then we'll be back for the town hall.
Oh.